Good morning. Today, we are going to see about some of the commonly seen gingival diseases among children. Gingival diseases affecting children are numerous and may progress to jeopardize the periodontium of the adult. The effects of periodontal diseases observed in adults mostly have their inception earlier in life. Dental practitioners have an important role to play in the early recognition and diagnosis of gingival and periodontal diseases to optimize treatment outcomes. Now, the gingival diseases could be classified as eruption gingivitis, chronic non-specific gingivitis, dental plaque induced gingivitis, acute gingival diseases, under which comes herpes simplex virus infection, recurrent aphthous ulcer, ENAG, or acute necrotizing ulcerative gingivitis, and acute candidiasis. Finally, gingival diseases that which are modified by systemic factors, which include gingival diseases associated with the endocrine system, gingival lesions of genetic origin, drug-induced gingival overgrowth, and finally, ascorbic acid deficiency gingivitis or scorbutic gingivitis. Now let's see one by one. First is eruption gingivitis. Gingivitis associated with tooth eruption is frequent. However, tooth eruption as such does not cause gingivitis. It may be caused by a greater risk of plaque accumulation in areas of shedding primary teeth and erupting permanent teeth, since oral hygiene may be difficult or even unpleasant to perform. The inflammatory changes accentuate the normal prominence of the gingival margin and create the impression of a marked gingival enlargement. That is, eruption gingivitis is a transitory type of gingivitis which is often observed in young children when the primary teeth are erupting, often localized and associated with difficult eruption, subsides after the teeth emerge into the oral cavity. Gingival inflammation and enlargement are common with the emergence of early permanent dentition, that is around 6 to 7 years of age, and young adolescents may develop eruption gingivitis during emergence of the premolars and permanent second molars. Now, what is the cause for this eruption gingivitis? Because the gingival margins receive no protection from the coronal contours of partially erupted teeth, food impingement on the gingiva can cause a localized inflammation of the tissue. Once the permanent tooth has fully erupted and plaque control measures are instituted, eruption gingivitis usually resolves without any intervention. Coming to the treatment aspect. Mild eruption gingivitis requires no treatment other than improved oral hygiene. If it is a case of pericoronitis, and that too a painful situation, it may be helped when the area is irrigated with a counter irritant such as peroxide. Pericoronitis that is accompanied by swelling and lymph node involvement should be treated with antibiotic therapy. Since pericoronitis is a result of inflammation of the pericoronal tissues of a partially erupted tooth, management can include applying pain management gels for the mouth consisting of lignocaine, a numbing agent. Definitive treatment can only be through preventing the source of inflammation. This is either through improved oral hygiene or by the removal of plaque stagnation areas through tooth extraction or gingival resection. Often, acute symptoms of pericoronitis are treated before the underlying cause is addressed. Next is dental plaque induced gingivitis. Dental plaque biofilm induced gingivitis usually is regarded as a localized inflammation initiated by microbial biofilm accumulation on teeth and considered one of the most common human inflammatory diseases. When dental plaque is not removed, Gingivitis may initiate as a result of loss of symbiosis between the biofilm and the host immune inflammatory response. The common features of plaque-induced gingivitis include 1. Clinical signs and symptoms of inflammation that is confined to the free and attached gingiva that which do not extend to the periodontal attachment. 2. Reversibility of the inflammation achieved by biofilm removal at or apical to the gingival margin. 3. The presence of a high bacterial plaque burden that is needed to initiate the inflammation. And 4. Stable attachment levels on a periodontium which may or may not have experienced a loss of attachment of alveolar bone. Gingivitis associated with poor oral hygiene is usually classified as slight or early gingivitis, moderate gingivitis, and advanced gingivitis. Practitioners have defined gingivitis based on the percentages of bleeding on probing sites. Example, mild if less than 10%, moderate if it is between 10 to 30%, and severe more than 30% sites, or based upon grading, graded from 1 to 5. The gingival index by Low also can be used to describe the intensity of gingival inflammation as mild, that is area with a minor change in color and little change in the texture of the tissue. Moderate, area with glazing, redness, edema, enlargement, and bleeding upon probing. And severe, that is area of overt redness and edema with a tendency towards bleeding when touched rather than probed. Lastly, the extent or the number of gingival sites exhibiting gingival inflammation can be described as either localized, that is less than 30% of the teeth affected, or generalized, that is more than or equal to 30% teeth affected. Now, coming to the treatment aspect, therapy for individuals with chronic gingivitis is initially directed at reduction of the oral bacteria and associated calcified and non-calcified deposits. An acceptable therapeutic result for these individuals is usually obtained when personal plaque control measures are performed in conjunction with professional removal of plaque, calculus, and other local contributing factors. Removal of dental calculus is accomplished by scaling and root planing procedures using hand, sonic, or ultrasonic instruments. The use of topical antibacterial agents to help reduce the bacterial plaque may be beneficial for the prevention and treatment of gingivitis in some patients. Three medicaments have been given the ADA seal of acceptance for the control of gingivitis. The active ingredients of these products are thymol, menthol, eucalyptol, and methyl salicylate, chlorhexidine digluconate, and triclosan. If properly used, the addition of a topical antiplaque agent to a gingivitis treatment regimen for patients with deficient plaque control will likely result in reduction of gingivitis. Now coming to acute gingival disease. First one is herpes simplex virus infection. Herpes virus causes one of the most widespread viral infection. The primary infection usually occurs in a child younger than 6 years of age who has had no contact with type 1 herpes simplex virus or who therefore has no neutralizing antibodies. Regarding the infection, 99% of all primary infections are of the subclinical type. Infection may also occur in susceptible adults who have not had a primary infection. The primary infection may be manifested by acute symptoms, which runs a course of 10 to 14 days. That may be characterized by diffuse erythematous, shiny involvement of the gingiva and adjacent oral mucosa. Varying degrees of edema, gingival bleeding may be present. Discrete spherical gray vesicles, which rupture and form painful small ulcers with red elevated halo-like margin and a depressed yellowish or grayish white central portion are also seen. It occurs occasionally without overt vesiculation. This is the appearance. So, the symptoms of disease include fiery red gingival tissues, malaise, irritability, headache, and pain associated with the intake of food and liquids of acid content. So, the characteristic oral finding once again is the presence of yellow or white liquid filled vesicles. In a few days, the vesicles rupture and form painful ulcers 1 to 3 millimeter in diameter. They are covered with a whitish gray membrane and have a circumscribed area of inflammation. The ulcers may be observed on any area of mucous membrane, including buccal mucosa, tongue, lips, hard and soft palate, and tonsillar areas. Large ulcerated lesions may occasionally be observed on the palate or gingival tissues or in the region of mucobuccal fold, and this distribution makes the differential diagnosis more difficult. Now, coming to the treatment. Treatment is supportive with analgesics and antipyretics. Topical application of magic mouthwash, which consists of diphenhydramine and magnesium hydroxide, has also been advocated. Mixtures with lignocaine added have demonstrated toxicity. Management considerations for acute herpetic gingival include antiviral medication, palliative therapy, and maintenance of fluids and electrolytes. Antiviral agents, example, acyclovir suspension or capsules, valacyclovir tablets, etc., may be beneficial if initiated early, ideally during the first 3 days of symptomatic infection. Pain can be controlled with topical anesthetic agents. Example, diclonine hydrochloride spray, tetracline hydrochloride lollipops, non-steroidal anti-inflammatory drugs, and popsicles. Because many patients have difficulty drinking, it is important to monitor for severe dehydration, which may necessitate hospitalization and parenteral fluid administration. In addition, in order to prevent auto-inoculation or disease spread to others, the patient should be instructed to avoid contact with active lesions. Next, we'll deal with recurrent herpes labialis. Herpes labialis is a rash of skin and mucous membrane, in particular the lips, and is characterized by erythema and blisters that are preceded and accompanied by burning pain. It is a harmless but often annoying ailment in immunocompetent patients, and it usually heals spontaneously within 10 days. Herpes labialis is contagious for individuals who have not been previously infected by the virus, and for those with weakened immune systems, example, those with HIV infection or undergoing chemotherapy. A primary infection with HSV1 is often asymptomatic. However, when symptoms do occur, young children often present with herpetic stomatitis characterized by fever and the formation of small blisters and ulcers of around 2 to 10 millimeter in diameter in front and around the mouth, on the tongue, and on the lips. This is a clinical appearance of recurrent herpes labialis. The recurrence of the disease has often been related to emotional stress, lower tissue resistance resulting from various types of trauma, excessive exposure to sunlight. Here, the use of sunscreen can prevent sun induced recurrences. Lesions on the lip may also appear after dental treatment, and they may be related to irritation from rubber dam material or even routine daily procedures. Coming to the treatment. Herpes labialis is a frequently occurring self-limiting ailment. Many patients do not consult their general practitioners but use over-the-counter medication. Treatment with agents consisting of Zinc oxide and zinc sulfate anesthetic or antiviral cream have a small favorable effect on the duration of the symptoms if applied promptly. This is also the case with oral antiviral medication. If antiviral medicine, either topical or oral, is started before exposure to the triggering factor like sunlight, it will provide some protection. In the long term, the number of relapses of herpes labialis can be limited with oral antiviral medication. Next, we'll see about recurrent aphthous ulcer, also known as canker sore. It is a painful ulceration of the unattached mucous membrane that occurs in school-age children and adults, also referred to as recurrent aphthous stomatitis. The peak age is between 10 and 19 years of age, characterized by recurrent ulcerations on the moist mucous membranes of the mouth, in which both discrete and confluent lesions form rapidly in certain sites, and this features round to oval crateriform base, raised reddened margins, and pain. Coming to the etiology, the cause of recurrent aphthous ulcers is unknown, but it is possible that the lesions are caused by local and systemic conditions and gastrointestinal disorders, genetic predisposition, immunologic and infectious microbial factors, delayed hypersensitivity to the L form of Streptococcus sanguis, and autoimmune reaction of the oral epithelium. Local factors include trauma, allergy to the detergent agent present in toothpaste, that is sodium lauryl sulfate, and salivary gland dysfunction. Nutritional deficiencies are found in 20% of the cases with aphthous ulcers. Also associated include the clinically detectable deficiencies of iron, vitamin B12, and folic acid. So, when we come to the treatment, we can see that the lesions generally persist for 4 to 12 days and heal uneventfully, leaving scars only rarely and only in cases of unusually large lesions. There is no definitive curative treatment for the condition. Possible systemic association with RAS must be ruled out, especially in cases where there is sudden development of ulceration in adulthood. Laboratory investigations such as complete blood count, red cell folate, serum ferritin levels, and vitamin B12 is recommended. So, the correct treatment is focused on promoting ulcer healing, reducing ulcer duration and patient pain, maintaining the patient's nutritional intake, and preventing or reducing the frequency of recurrence of the disease. Also, analgesic medicines or systemic immunomodulating or immunosuppression agents could be given. Example, topical corticosteroid. Example, that is 0.5% fluocinolone or 0.025% triamcinolone is applied to the area with a mucosal adherent like isobutyl cyanoacrylate or orabase before meals and before sleeping. This may also be helpful if applied 4 times daily. Next, we will see about acute necrotizing ulcerative gingivitis or Vincent's infection, which occurs occasionally in children 6 to 12-year-old, common in young adults. ENA can easily be diagnosed because of the involvement of interproximal papillae. Presence of pseudomembranous necrotic covering of marginal tissue is another important feature. Like clinically, the patient may be presenting with poor appetite, temperature as high as 104 degree Fahrenheit, general malaise. When we see the clinical appearance of the lesion, it will have the following features: punched out appearance due to ulcerated and necrotic papillae and gingival margins. Ulcers are covered by yellowish white or gray slough termed pseudomembrane. Removal of the slough results in bleeding and underlying tissue becomes exposed. A fetal X-ray is often associated but can vary in intensity. Seldom associated with deep pocket formation, as extensive gingival necrosis often coincides with the loss of crestal alveolar bone. The involved papillae are separated into facial and lingual portion with an interposed necrotic depression. Swelling of lymph nodes and increased bleeding tendency are often present. Fever malaise are not consistent features, but the oral hygiene in these patients is usually poor. Now, what about the treatment? The treatment of NR should be approached in successive stages, including treatment of the acute phase, treatment of any pre existing condition, treatment of disease sequelae, and transition to supportive or maintenance phase. Treatment of the acute phase aims to halt tissue destruction and to control the patient's discomfort. This involves gentle ultrasonic debridement of superficial gingival plaques and calculi, along with localized oxygen therapy directed at necrotic lesions. The use of 0.12% chlorhexidine gluconate mouth rinse should be considered, a suggested regimen being twice a day for 30 days. Systemic antimicrobials are considered in the acute phase in cases with poor response to debridement or those with symptoms of systemic involvement, including fever, malaise, vomiting, etc. Metronidazole of the dosage 250 mg thrice daily is a common first drug choice due to its activity against anaerobes. After the acute phase has been controlled, treatment of any pre existing condition, such as chronic gingivitis, should be initiated. This stage involves professional prophylaxis in the form of scaling and root planing and the establishment of maintenance or oral hygiene methods by the patient. Predisposing factors including smoking, poor sleep hygiene, and stress should be addressed. Gingivectomy or gingivoplasty procedures can treat any superficial craters. The main goal of maintenance phase is to comply with oral hygiene practices and control any predisposing factors. If proper maintenance is not carried out, relapses are likely to occur. Next, we'll see about acute candidiasis. Acute candidiasis, otherwise known as thrush, candidiosis, or moniliasis. This form of candidiasis classically presents as acute infection. It is commonly seen in the extremes of age, immunocompromised patients, especially in AIDS, diabetics, patients on corticosteroids, prolonged broad spectrum antibiotic therapy, hematological, and other malignancies. On the oral surfaces, the superficial component presents as white to whitish yellow creamy corn plaques resembling milk curds or cottage cheese. These plaques consist of desquamated epithelial cells, tangled aggregates of fungal hyphae, fibrin, and necrotic material. The superficial pseudomembrane can be removed by wiping gently, leaving behind an underlying erythematous and occasionally bleeding surface. The oral surface frequently involved include labial and buccal mucosa, tongue, hard and soft palate, and oropharynx. Now, coming to the treatment, you can make use of antifungal antibiotics to treat thrush. For infants and very young children, a suspension of 1 ml, that is 1 lakh unit of nystatin or mycostatin, may be dropped into the mouth for local action 4 times a day. And this drug is non-irritating and non-toxic in nature. Clotrimazole suspension of 10 mg per ml, 1 to 2 ml is applied to the affected areas 4 times daily, and this is an effective antifungal medication. Systemic fluconazole suspension of 10 mg per ml is safe to use in infants at a total dosage of 6 mg per kilogram or less per day. Next is about chronic non-specific gingivitis. A type of gingivitis commonly seen during the pre-teenage and teenage years is often referred to as chronic non-specific gingivitis. The chronic gingival inflammation may be localized to the anterior region or may be more generalized. Although the condition is rarely painful, the fiery red gingival lesion is not accompanied by enlarged interdental labial papillae or closely associated with local irritants. Gingivitis showed little improvement after prophylactic treatment and may persist for longer periods without much improvement. This is the image of chronic non-specific gingivitis. Now, the causes for this type of gingivitis is complex and is considered to be based on a multitude of local and systemic factors. Possible factors could be hormonal imbalance, inadequate oral hygiene, that which allows food impaction and the accumulation of materia alba and bacterial plaque. And this is undoubtedly the major cause of this chronic type of gingivitis. Insufficient quantities of fruits and vegetables in the diet, leading to a subclinical vitamin deficiency, may be an important predisposing factor. An improved dietary intake of vitamins and the use of multiple vitamin supplements will improve the gingival condition in many children. Malocclusion, which prevents adequate function, and crowded teeth, which make oral hygiene and plaque removal more difficult, are also important predisposing factors in gingivitis. Carious lesions with irritating sharp margins, as well as faulty restorations with overhanging margins, both of which cause food accumulation, also favor the development of chronic type of gingivitis. Mouth breathing is often responsible for the development of chronic hyperplastic form of gingivitis, particularly in maxillary arch. So, all these factors should be considered contributory to chronic non-specific gingivitis and should be corrected in the treatment of the condition. Now, coming to the final classification, that is the gingival diseases modified by systemic factors. So, as said before, this include gingival diseases associated with endocrine system, gingival lesions of genetic origin, drug-induced gingival overgrowth, and scorbutic gingivitis. So, first is gingival disease associated with endocrine system. Puberty gingivitis is a distinctive type of gingivitis that occasionally develops in children in the prepubertal and pubertal period. Like enhanced levels of gingival inflammation without increased levels of plaque accumulation occur in children at puberty. The cytoplasm of gingival cells contain specific high affinity, low capacity receptors for both estrogens and testosterone. Estrogen receptors are found in the basal and spinous layers of epithelium and in the fibroblasts and endothelial cells of small vessels in the connective tissue. Thus, gingiva appears to be a target organ for some of the steroid hormones. The relationship between elevated levels of circulating sex hormones and prevalence of gingivitis in puberty is strengthened by the observation that during adolescence, gingivitis peaks earlier in girls, that is around 11 to 13 years, than in boys, around 13 to 14 years. Proportion of Provotella intermediates correlated with the levels of plasma estrogen and progesterone, and in vivo evidence is obtained indicating that these hormones are nutrients for Provotella intermedia. Thus, it is characterized by pronounced inflammation, bluish red discoloration, edema, and enlargement, which result from local irritants that would ordinarily elicit a comparatively mild gingival response. So, as said before, the anterior segment may be present in only one arch. The lingual gingival tissue generally remains unaffected. So, the treatment include maintaining improved oral hygiene, removal of all local irritants, restoration of carious tooth, dietary changes necessary to ensure an adequate nutritional status, and oral administration of 500 milligram of ascorbic acid. However, improvement did not occur until vitamin had been taken for approximately 4 weeks. Severe cases of hyperplastic gingivitis that do not respond to local or systemic therapy should be treated with gingivoplasty. Recurrence of any hyperplastic tissue will be minimal if adequate oral hygiene is maintained. Next, we'll see about gingival lesions of genetic origin. There is hereditary gingival fibromatosis. It is a benign, non-hemorrhagic fibrous gingival overgrowth that can cover all or part of the teeth. Authors have agreed that there is more subepithelial fibroblast proliferation and greater collagen and fibronectin synthesis, and at the same time, a reduction in the matrix metalloproteinases interested with collagen degradation. HGF normally appears with the eruption of permanent teeth, although cases have been described in primary teeth and even at birth. The HGF gingiva has a rosy color, fibrous appearance, and marked stippling, but no sign of inflammation. It covers the teeth partially or totally and can be localized or generalized with a variable degree of severity but does not affect the bone. It usually interferes with speech, lip closure, and chewing, but above all, at the ages at which it appears, it can become a psychological burden and affect patients' self esteem. The condition is not painful until the tissue enlarges to the extent that it partially covers a closer surface of molars and become traumatized during mastication. So, regarding the treatment, surgical removal of the hyperplastic tissue that achieves a more favorable oral and facial appearance. Hyperplasia can recur within a few months after the surgical procedure and can return to the original condition within a few years. Importance of excellent plaque control should be stressed to the patient because this delays the recurrence of gingival overgrowth. Now, next is drug induced gingival overgrowth. Many drugs have been reported to induce gingival overgrowth, and this include phenytoin, cyclosporin, calcium channel blocker, valproic acid, and phenobarbital. So, coming to phenytoin induced gingival overgrowth, phenytoin it's an anticonvulsant drug. It is used along with phenobarbital or other anticonvulsants to prevent or treat generalized tonic-clonic seizures, complex partial seizures, or seizures occurring during or after neurosurgery. One of the major side effects of anti-epileptic drugs, particularly phenytoin, is gingival overgrowth. The exact etiological factors responsible for the development of this is still unclear. However, some contributory factors have been found associated with this condition. These include bacterial biofilm, inflammation, genetic factors, and other risk factors. Drug induced gingival diseases were categorized as dental plaque induced gingival diseases in the most recent classification system for periodontal diseases. In this classification, dental plaque is considered as a major contributory factor in the etiology of drug induced gingival overgrowth. The role of chronic inflammation as a contributory factor in the development of gingival overgrowth can be described by the fact that chronic inflammation resulting from persistent irritating agent usually leads to fibrosis as a part of reparative process. The affected gingival tissue in patients with this condition has less inflammation and more fibrosis. Genetic factors may also play a significant role in the development of phenytoin induced gingival overgrowth, as not all patients receiving therapy develop gingival overgrowth. Genetic factors could affect patients' susceptibility to the unwanted effects of the drug by influencing several factors involved in drug plaque induced inflammation. So, this is a clinical appearance of phenytoin induced gingival overgrowth. That is, it begins to appear as early as 2 to 3 weeks after initiation of therapy, peaks around 18 to 24 months. There is painless enlargement of interproximal gingiva. Buccal anterior segments are more often affected than lingual and posterior segments. Unless secondary infection or inflammation is present, the gingiva appears pink and firm and does not bleed easily on probing. As the interdental lobulations grow, Clefting becomes apparent at the midline of the tooth. With time, the lobulations coalesce at the midline, forming pseudo pockets and covering more of the crown of the tooth. Epithelial attachment level usually remains constant. In some cases, entire or closer surface of the teeth becomes covered. The lesions may remain purely fibrotic in nature or may be combined with a noticeable inflammatory component. So, patients with mild condition, that is less than one third of the clinical crown covered, require daily meticulous oral hygiene and more frequent dental care. For patients with moderate condition, that is one third to two thirds of the clinical crown covered, meticulous oral home care and judicious use of an irrigating device may be needed. In addition, prophylaxis and topical stannous fluoride application is recommended. If there has been no change, consultation with the patient's physician concerning the possibility of using a different anticonvulsant drug that may be helpful. If no improvement occurs, surgical removal of the overgrowth must be recommended. For patients with severe condition, that is more than two-thirds of the tooth covered, who do not respond to the previously mentioned therapeutic regimens, surgical removal is necessary. Gradual recurrences of the fibrous tissue usually follows the treatment. There is success in controlling the gingival overgrowth with positive pressure appliances. Other drugs that have been reported to induce gingival overgrowth in some patients include cyclosporine, calcium channel blockers, valproic acid, and phenobarbital. As with all disorders affecting periodontal tissues, maintaining excellent oral hygiene is the primary key to successful therapy. Finally, it's ascorbic acid deficiency gingivitis or scorbutic gingivitis. Scorbutic gingivitis is associated with vitamin C deficiency and differs from the type of gingivitis related to poor oral hygiene. The involvement is usually limited to the marginal tissues and papilla. Child may complain of severe pain and spontaneous hemorrhage is evident. Severe situation is rare in children. This may occur in children allergic to fruit juices. Clinically, there will be inflammation and enlargement of marginal gingival tissue and papilla in the absence of local predisposing factors. Treatment involves daily administration of 250 to 500 milligram of ascorbic acid. Older children and adults may require 1 gram of vitamin C for 2 weeks to speedy recovery. Thus, to conclude, gingivitis is a reversible disease. Irrelevant of age, gingival diseases have been found to occur right from children to older individuals. The common myth existing among us is that gingival diseases are pertained only to adulthood. But now we are clear about the fact that the inception of gingival diseases could be from childhood as well. Either incomplete knowledge about gingival diseases in childhood or ignoring them would jeopardize the periodontium in adults. This further highlights the need for patient education, parent counseling, and regular periodontic gingival examination for maintaining a healthy and hygienic oral cavity in childhood. These are the references. Thank you.